Hi there. Thank you, Becky. My name is Dr. Mark Manseau, and I want to welcome you all to The Truth About Suicide and Guns with Becca Adeskovitz, MPH, and Jenny Lynch, JD, MS, from the Brady Center to Prevent Gun Violence. I'm a psychiatrist in New York City, and because suicide is the most common way that people die by guns, and it's probably the least common way that people talk about deaths from guns, this is an issue that's near and dear to my heart, and we're going to hear some really great information and education about this issue tonight. So Rebecca Adeskovitz, MPH, is the Senior Program Manager for the Brady Center to Prevent Gun Violence. Rebecca Adeskovitz joined the Brady's Public Health and Safety Team as a Program Manager in April 2013. Since then, she has provided a day-to-day management for Brady's public awareness and education programs aimed at inspiring safer attitudes and behavior around guns. She brings a unique set of skills and experiences to her work, as well as a deep passion for social services and social justice. Prior to joining Brady, Rebecca worked for the Salvation Army on diverse projects such as homeless shelters and feeding programs, foster care and adoption services, and HIV case management. She started her career in education working as a high school social studies teacher. Rebecca holds a master's degree in public administration and more recently completed a graduate degree in global public health from NYU, which happens to be my academic institution. Jenny Lynch actually is not going to be able to join us until the very end for questions, but she is the Director for Public Health and Safety at the Brady Center to Prevent Gun Violence. Since 2005, Jenny has been working to keep families, schools, and communities safe from gun violence. At Brady, Jenny oversees public health and safety campaigns asking Safe Kids, Speak Up, and Suicide-Proof Your Home. These proven programs provide simple, empowering solutions that shift dangerous attitudes and behaviors and save lives. Through partnerships and leading health education, law enforcement, and media organizations, Jenny manages the national implementation of these campaigns as well as community-based programs. In addition to her experience in managing nonprofit organizations, Jenny taught elementary school in the Bronx to educators, New York, and practiced family law in Chicago, Illinois. Jenny earned a BA from Clark University, an MS in education from Lehman College, and a JD from Benjamin Cardozo School of Law. So I just would like to welcome Rebecca, and we're going to hear the presentation, and then we'll probably have some time for questions at the end. At the end, when it is time for questions, please push *6 to unmute your line in order to be able to ask questions, but please do keep your line muted until that time. Thank you. Rebecca?
Thanks, Mark, and thank you for joining us today. Jenny and I are very happy for this opportunity to talk about the link between guns and suicide and to share with you the research from our latest report. First, I'll take you through our presentation, and I'll be sure to leave plenty of time for questions at the end. I'd like to begin by taking a step back and acknowledging that for many people, when we imagine gun violence, we think about mass shootings, gang-related incidents, and domestic violence. And when we talk about how to prevent gun violence, we overwhelmingly talk about preventing homicide. But that's not how most people die by guns. There are 20,000 gun suicides in the United States every year, 2/3 of all gun deaths. These tragedies rarely make the news or prompt action from our lawmakers, but they add up to a national tragedy of staggering proportions. In a gun violence prevention group, whose goal is to reduce gun deaths, we cannot continue to allow these deaths to not be a part of the conversation, especially when the research is as compelling and clear and actionable as it is here. The report we are going to summarize tonight was released earlier this month to coincide with National Suicide Prevention Week. We were very pleased with the positive feedback that we received, particularly an editorial written by the New York Times editorial board that featured the report. Our goals in writing the report were to increase understanding of the strong link between firearms and suicide, heighten awareness of the increased risk for suicide associated with having a firearm in the home, and raise awareness that suicide can be prevented by limiting access to lethal suicide means, such as firearms and medications. Ultimately, we want families to understand the risks of a gun in the home. To really get an understanding of these issues and how they intersect, it's important to look at recent trends. While the overall death rate from gun violence has remained unchanged for more than a decade, the patterns of firearm homicide and suicide have changed dramatically. Over the past decade, the rate of firearm homicide has continued a steady decline. At the same time, the firearm suicide rate has begun increasing more than 13% between 2007 and 2013. Any gains being made by declining firearm homicide rates are being offset by the rising firearm suicide rate. And as this graph shows, the gap between firearm suicide and firearm homicide is growing. In 2013, suicides accounted for 63% of gun deaths, the highest share since at least 1981. In 2007, the share of gun deaths caused by suicide was 55%. And to better understand the impact of suicide, and firearm suicide in particular, let's take a look at how it compares to other leading causes of death and injury. Overall, we know that suicide is the 10th leading cause of death among all ages in the U.S. And suicide is the second leading cause of death for 15 to 34-year-olds and third among 10 to 14-year-olds. But when we look at suicide as a leading cause of injury deaths, as in the table shown here, we can see the considerable impact it has across all age groups. We can also see that firearms are the leading cause of suicide death among all age groups, the only exception being the 10 to 14-year-old age group. In fact, firearms are used in 51% of all suicide deaths, more than all other methods combined. Even though firearms are used in only a small fraction of suicide attempts, they account for over half of all suicide deaths. Why is it that firearms differ from other suicide methods? What makes them so deadly? For one thing, firearms have a very high case fatality rate. 85 to 91% of firearm suicide attempts are fatal, compared with just 3% or less for other methods, such as overdosing and wrist cutting. Looking at a side-by-side comparison of completed suicides and suicide attempts by method, we can see that attempting suicide with a firearm drastically increases the likelihood of suicide and leaves little chance for survival. Firearms are also quick, easy, and involve little planning. Unlike other methods, they do not provide an opportunity to reconsider or halt mid-attempt, which is particularly important considering that more people abort their attempts than carry it through. Another reason is that many suicides have an impulsive component. Although we tend to think of suicide as being carefully planned, many suicides involve very little planning. In a frequently cited study, 153 survivors of serious suicide attempts were interviewed about when they had made the decision to kill themselves. 70% had said that they had decided to kill themselves within an hour of the actual attempt. 24% said within less than 5 minutes. Suicidal crises are often triggered by an immediate stressor, such as the loss of a job or the breakup of a relationship. And studies have shown that a large number of suicides take place within 24 hours of a crisis, particularly among youth. Lastly, firearms are common in the U.S. Approximately 1 in 3 households have a firearm. Despite the risks of keeping a gun in the home, many gun owners do not store their guns safely. We know that from data from the 2002 Behavior Risk Survey, the last year that included questions about firearm ownership and storage, the results showed that nearly 2 million children live with unlocked loaded guns. Looking at a map of the U.S., we can clearly see that the connection between firearm availability and suicide. The states here are shaded according to rates of household firearm ownership. Those states with the highest rates are in the darkest shade of purple. Comparing that with the rate of firearm suicide, we see that overall, those states with the highest rates of firearm ownership have the highest rates of firearm suicide. Wyoming, Alaska, Montana, Idaho, and Oklahoma have the highest rates of firearm suicide. They all have rates of household firearm ownership 12 to 20 percentage points higher than the national average. And the reverse is true for states with the lowest rates of firearm suicide. They are all well below the national average in household firearm ownership. The best evidence of the connection between firearm availability and suicides comes from case control studies. Every U.S. study that has examined the relationship between suicide and firearms has found that the presence of a firearm in the home increases the risk of suicide. Firearm owners are not more suicidal than non-firearm owners. Their suicide attempts are just more likely to be fatal. A recent meta-analysis combines the results from 14 national and international studies, finding that access to firearms increases the risk of suicide more than 3 times. Given the connection between firearms and suicide, making firearms less available would seem to be a logical strategy for prevention. Since many suicides are impulsive, separating someone from the means to self-harm takes away their ability to act quickly. Because suicidal crises are often short-lived, typically lasting only minutes or hours, this delay would allow the impulse to pass without being realized. The concept of means reduction does not only apply to firearms. Other examples include detoxification of domestic gas, barriers at jumping sites, modifications in drug packaging and toxicity, and restrictions on pesticides. This diagram was developed by Kathy Barber and Matt Miller from the Harvard Injury Control Center, and it provides a good illustration of how means reduction works. As we can see, restricting access to firearms can either temporarily or permanently delay a suicide attempt. Since the acute crisis period is relatively short, this delay can allow time for the crisis to pass and for the suicidal individual to think rationally again. This would then lead to a drop in suicides by that method and possibly a drop in the overall suicide rate. One criticism of the means reduction approach is that people who want to kill themselves will just find another method. The research on this is somewhat mixed, but many studies have shown that the risk of method substitution is relatively low. This means that some people will substitute another method, but certainly not all. But even if another method is substituted, it is likely to be less lethal than a firearm, which will still increase the chances of survival. It's important to note that increasing the likelihood of surviving a suicide attempt increases a person's long-term survival as well. Studies have shown that 90% of people who attempt suicide and survive do not go on to die by suicide. In fact, studies have shown that 70% will not reattempt. Firearm suicide affects all ages, races, and both sexes. However, some groups are at especially high risk. Men are 4 times more likely to die by suicide than women. Among men, the risk increases with age, and this is true of firearm suicide, which we have shown here. Although adolescents and young adults have relatively low rates, the impact of suicide relative to other causes of death is high. And we discussed earlier that suicide is the second leading cause among 15 to 24-year-olds and third among 10 to 14-year-olds. Here we can see that the reason that men are much more likely to die by suicide is that they are more likely to use a firearm. Women attempt suicide far more often than men, but they are more likely to use less lethal methods. There is broad consensus among public health experts that means reduction should be considered an essential strategy of any comprehensive prevention strategy. Unfortunately, despite the potential of means reduction for saving lives and lowering suicide rates, It has been largely underutilized in the U.S. However, there are several promising opportunities for prevention, many that can have an immediate impact. As you can see here, 82% of adolescent firearm suicides involve a gun belonging to a family member. Encouraging parents to remove or securely lock household firearms can help to mitigate this risk. We also know that over 70% of older Americans who die by suicide use a firearm. Families and caregivers should be counseled to approach the removal of firearms as they would taking away the car keys. It should be something that all families and caregivers are thinking about as their parents and family members get older. We also know that older Americans are more likely to own a gun, which makes this particularly important. Research has also shown that 77% of people who die by suicide had contact with a primary care provider in the year before their death. Nearly half in the month before their death. Screening patients for suicide risk and asking about access to lethal means, particularly firearms, should become routine for primary care providers as well as other healthcare providers. And we know that that counseling among providers works because studies have shown that parents are more likely to store their firearms safely after having discussed the issue with their doctor. It's important that we stop thinking of firearms as just the means to suicide. They are an important and sometimes the most important risk factor and ought to be considered and discussed right alongside mental illness, substance abuse, and family history. Although the dangers of keeping a gun in the home have been well established, many Americans still believe that a gun makes a home safer, and that number is increasing. As you can see here from this 2014 Gallup poll, 63% of Americans believe that a gun in the home makes it safer as opposed to more dangerous. The percentage has nearly doubled since 2000, when over half said guns make homes more dangerous. This is a disturbing trend and one that Brady is working to address. We want everyone to be aware of and understand the risks of keeping a gun in the home so that they can make informed decisions that will keep their families safe both in their own homes and the homes of friends, relatives, and neighbors. When children are young, parents take all sorts of measures to protect them from harm. They cover electrical sockets, they add safety latches to cabinets, and keep medicine and other hazardous products out of reach. But as children get older, parents still need to be vigilant about protecting their safety. Brady's Suicide Proof Your Home campaign provides simple, practical steps that parents can take to reduce their child's risk of suicide, such as disposing of or locking up firearms and medications. Much like putting locks on cabinets can keep young children safe from household cleaning products and chemicals, locking up guns can keep adolescents safe from suicide. Suicide Proof Your Home was developed through an innovative partnership with the Rhode Island Department of Health and was funded by a grant from SAMHSA's Garrett Lee Smith Suicide Prevention Program. The program is designed to educate families about the risks of guns in the home, and we found that the program has had really great results. An evaluation of the first 2 years revealed that 97% of parents surveyed believed the program's message was important, and more than half had already made changes or planned to make changes to suicide-proof their home. The program is currently being implemented in locations across the country, helping to make homes, families safer, and entire communities safer. We have materials and information about the program for anyone who is interested. And I'm going to wrap up by letting you know that our report, The Truth About Suicide and Guns, is available on our website. It expands on a lot of what I included in this presentation, and it also includes references for all of the studies and data presented for anyone who's interested. And I'd also like to invite all of you to join us on October 26th to 28th in Washington, D.C. for Brady and the American Public Health Association's National Summit. The summit will focus on gun violence as a public health problem and highlight proven solutions to dramatically reduce gun deaths and injuries. You can visit our website to register and find out more information, and the same goes for the report. It's available on our website and through the link here. And of course, now we'll be available for questions, but if you'd like additional information or you'd like some materials for our Suicide Proof Your Home campaign, you can always contact us, and we have our contact information here.
So thank you so much, Rebecca, for that excellent presentation. A lot of great information there. I definitely, a lot of that resonated quite strongly with me. Suicide is obviously an important thing that psychiatrists look for and assess for, but sadly, research shows that psychiatrists are not much better than any person from the public in predicting suicide. And what we can't predict, we can't prevent. So means restriction is an extremely important method of trying to get at that from a public health perspective. I'm just wondering, I think, we finished pretty early, so we have plenty of time for questions. So if anyone has any questions, feel free to press *6 to unmute your line. Wait for the signal, which will happen shortly thereafter that says line unmuted, and then ask your question. And then if you could remute your line to allow for less feedback to hear the answer, that would be very helpful. I have one question. So 47%, I think, of people in one study who die by suicide saw their primary care physician within the 30 days prior to their death. And as you point out, over 70% of people saw their primary care physician within the year prior. So it seems like suicide prevention should be an important piece of the healthcare visit for primary care physicians, especially since most people who die by suicide aren't in mental health treatment. And once people enter mental health treatment, their risk of dying by suicide goes down, even though mental illness is a major risk factor for suicide. So I'm wondering, since primary care physicians are so busy and there's so many things being asked of them and there's so many guidelines that they have to follow and so many boxes they have to check with every single visit in order to keep patients healthy, I'm wondering if there are any quick, easy-to-use tools that the Brady campaign has resources on that can be available to primary care physicians.
Hi, so this is Jenny. I'm apologizing in advance for my voice. A couple of things. I know that NPA produces a card, a little palm card, which has some good kind of sentence starters or talking points, but you're right, that does require time. All these things require time. It's hard to substitute for a conversation and of course the credibility that comes with having a conversation and relationship with your client. Materials in the office waiting room, things that go along with the patient history, things that you can hand off to the client or patient in the absence of a conversation. Clearly shouldn't replace a conversation if you have some concerns, but are of course better than not. And it seems that, although there's not a lot of research in this area, when we kind of lump together, the gun in the home with kind of other anticipatory guidance type conversation that seems to make both the person asking the question and the person and the patient or client more comfortable. So your only conversation isn't about guns, for example. And that was our thinking when we produced the Suicide Proof Your Home material. So to put it in the context, first of all, to kind of harken back to the notion of child-proofing as something that people already understand and know about, but also talking about guns in the same context as medication and in the same context of open communication with children seems to make people a little more comfortable. So short answer is we know that there's lots of time constraints and it's hard to kind of think of good substitutions, but those are two things that kind of come to mind as potential options.
This is Mark again. If anyone has any questions, feel free to unmute their line by pressing *6. Wait for the signal line unmuted, and then speak up.
Hi, I have a question. Hello?
Hello? Oh, go ahead. We hear you.
Question about gag laws. In Florida, there are laws that prevent physicians from inquiring about guns and firearms in the house, and I'm wondering what you recommend and what is being done to try and fight against those gag laws.
Yeah, so that particular lawsuit, Brady is co-counsel. Actually, it's not being enforced right now. So healthcare providers in Florida, pediatricians in Florida can continue to ask and do continue to ask, and they're not being prosecuted. The law's not being enforced because the case is still being litigated. It's obviously something we're very concerned about, not just in Florida, but across the country. And we feel that the ability for healthcare providers to talk to their families about the risks of guns is exactly the same as talking about tobacco or talking about proper diet or car seats or any of these other issues. And it is unfortunately part of a comprehensive effort to silence those conversations. There's definitely a lot of individual pediatricians and the Florida AAP who are doing some really good work on kind of helping pediatricians and how to have this conversation in the safest and potentially least controversial way possible. There are many pediatricians who don't care, who feel like their primary responsibility is the health and safety of their patients, and they're going to have that conversation kind of either way. But there's definitely lots of guidelines about how to ask, how to have the conversation, the record keeping that's involved in it, and making it part of a conversation as opposed to an inquiry is probably kind of the advice that's rising to the top. So we're monitoring this litigation. We're obviously part of the Florida litigation, and we're monitoring this type of litigation that's being raised in other parts of the country. I think the more healthcare providers, pediatricians who do ask, the more comfortable it will be. Just like any other issue, we're kind of norming both the healthcare community and families that we can have this conversation and outside of politics.
I just want to mention, too, that that's one of the topics that's going to be addressed at our Brady Summit, joint summit with APHA. And so we're going to have some really great speakers, including John Lowy, who's the director of our Legal Action Project.
And this is Becky.
This is Mark
I'm the
again.
project manager at NPA, and I just would add a little bit to that. NPA has been active on this issue of the medical gag laws, not only around guns, but also around women's health and in a new area around fracking. And we'll be hosting, in conjunction with the American Medical Students Association, a webinar that will look at fracking issues and medical gag laws on October the 5th. and folks that want to find out more about the gun-related medical gag laws, we have a webinar that we did similar to this tonight with the Law Center to Prevent Gun Violence that is recorded and available within our webinar series. And you can get to that from the NPA website. I'll go ahead and bring that back up on the screen. If you go to NPAlliance.org, and in the center of the home page under Explore Our Work is a direct link into our gun violence prevention section where you can find a recording of the webinar in June with the Law Center to Prevent Gun Violence. So thank you. Back to you, Mark.
Yeah, so
one other thing. I would add that also at the NPA National Conference, which is actually the week before the Brady Conference in Washington, D.C., October 17th and 18th, we will also be having some presentations and speakers related to these topics. So if you're in D.C. area or looking to be the weekend of October 17th and 18th and aren't already registered to join us at the NPA Conference, please consider joining us, and you can find the links and more information also through the NPA website.
So I just want to remind people when they ask a question, if you feel comfortable, if you could just briefly state your name before asking the question. I also wanted to just mention one thing about gag laws is it's a little tricky. If you do happen to have a gag law in your state, it's a little tricky if you're going to be asking blanket every single patient about gun ownership. That's the reason the law was passed for pediatricians who do that, for good reason. But if you have an adult without adolescents or children in the home, you can screen for suicide risk first, and if there is suicide risk, then you have a clinical justification to ask about guns, and then you should be able to get around any gag law as far as I'm aware. And one valid, very quick scale that is quite predictive, sensitive, and specific for suicide risk is the Columbia Suicide Severity Rating Scale Screener. The most, if someone endorses every question yes, the most number of questions you would ask is five questions. So it's really quick. It's well studied, it's validated, and it's worth considering. It's freely available online, and it's worth considering using. More questions?
Hello, I have a question.
Go ahead. Please go ahead.
Hello, I have a question. Dr. Frederick Jones. The question is terminology and the emphasis on gun safety rather than talking about gun control, gun regulation. It's been very successful in aviation safety and increasingly in patient safety terminology, and it may allow healthcare professionals to be more attuned in the concept of safety.
We agree. We see very few of what's called now gun violence prevention organizations still using the term gun control. You still will see that sometimes in political conversations, but we agree. It's been tested that kind of gun violence prevention, gun safety are more less charged, and I think that the remaining holdout has really been the media in not changing. You'll still see the use of gun control a lot in the media, and it's something that we have worked on and will continue to work on, but it definitely has been successful on our end. And I think also really of late trying to reframe gun violence prevention as a public health problem, and looking at it from a public health perspective has also helped to kind of broaden acceptance for the field, and even wider than the criminal justice and the traditional gun violence prevention groups that have been working on the issue for a long time, to include lots of other
organizations working on a number of different issues. So that's been very successful as well.
This is Mark again. Does anyone else have any questions? If so, feel free to press *6, unmute your line, and introduce yourself and ask the question. Okay, it seems like we may not have any more questions right now. Rebecca, Jenny, do you have any final thoughts, final words, words of wisdom or take-home points that you'd like to share?
Sure. Well, we want to, of course, thank everyone for their time. Encourage anyone who's interested, of course, to reach out to us with any specific questions. Take a look at the report. Most importantly, talk about firearms and the risk of firearms and suicide in your professional circles. That would be fantastic, and we know would frankly save lives. And then I would encourage you. I think a question came up last time around veterans, and I think there's lots of things we don't know. We know that's an area of particular interest, and we would encourage you to take a look. The New York Times has done a recent series profiling veteran suicide that's gotten a lot of, I think, well-deserved attention. And we'd encourage those of you who are interested to take a look at that. It's definitely a evolving knowledge base, and we don't have all the answers, but we know that it's an area that I think particularly we will see more and more attention around. So please take a look, and maybe we can share that link if we want. If Becky doesn't have it, we'll share it afterwards. And I think it's a really good long piece that's worth taking a look at.
I just wanted to also mention that I think it's important to recognize that gun violence prevention is something that we can all get involved with. There's a role for everybody. I think most of you as physicians and healthcare providers certainly have an important role to play, but even as family members and parents and brothers and sisters, there are a lot of other things you can do. In the presentation, we mentioned about securing guns and definitely other things such as asking family members and asking about firearms in other people's homes, and just starting this conversation even outside of the doctor's office, I think is important because it's important for everybody to begin talking about it.
Okay, well, thank you so much. Any final questions? Okay, well, I think we will end early tonight. Any final words, Becky?
Just to let folks know that we'll have this recording of this evening's presentation along with the resources that Jenny and Rebecca mentioned on the NPA website, along with some other useful resources. So you're welcome to revisit this information tonight or share it with others. And a reminder of our conference coming up on October 17th and the 18th in Washington, D.C. So thank you, Mark. Thank you, Jenny. Thank you, Rebecca, for the very valuable information tonight.
Thank you.
Thank you so much. Yep. Good night, everyone.
Good night.
Good night.